Hey everybody, my name is Dr. Scott Giacomucci. I'm the author of Trauma-Informed Principles in Group Therapy, Psychodrama, and Organizations, Action Methods for Leadership. And today I want to talk to you about trauma-informed principles in group therapy. So I'm going to go through different content from the middle chapters of the book, chapters 5 through 10, which discuss the 6 trauma-informed principles outlined by SAMHSA as they relate to group psychotherapy. I want to talk about this first trauma-informed principle of safety as it relates to group psychotherapy. And to begin that conversation, I think we have to start at the beginning. Before we start a psychotherapy group, first, we have to consider our screening and assessment process, our pre-group selection process, as it relates to that group. Irving Yalom has a quote in his book. He's one of the most famous group psychotherapists. He says that good group therapy begins with good client selection. Clients improperly assigned to a therapy group are unlikely to benefit from their therapy experience. So this really rings true in my experience as a group therapist and as an organizational leader and director of a group therapy program and inpatient, that one of the primary factors that leads to successful therapy groups is thorough pre-group screening and assessment. And one of the primary things that leads to unsuccessful groups or very chaotic groups or conflict that's difficult to resolve in groups or re-traumatization in groups or just simple dissatisfaction in groups is when we really do a sloppy job of pre-group screening and assessment. So this pre-group screening and assessment really promotes a sense of safety for the individual that we're screening, but also for the rest of the group. Safety is threatened when an agency or group worker accepts a client to a group who really needs a different level of care or a different type of group treatment. Groups function best when there's some sort of overlap between the individual goals and experience and the collective goal and experience. And one of the things that I think is especially important in assessing appropriateness for a group that doesn't get talked about enough is that we're bringing together a collection of individuals, and we need to assess that their window of tolerance is somewhat similar. That if we have a bunch of people in a group who have a really wide window of tolerance, and they have lots of coping skills and they're able to tolerate difficult emotions, and they've already done some of the early stages of trauma recovery and they're ready to go into trauma processing. But we also have others in the group who have a much thinner window of tolerance, and they might not have coping skills on board yet. They might not have internal ego strength and internal resources that they've cultivated, and they're in an earlier phase in their trauma recovery. It can really lead to incongruence in where the group is at in their recovery process, and it can make it difficult for us as the facilitator to meet all the needs of each individual in the group. And that some people are ready to go deeper into trauma processing, while others are really not ready to do that or be in the room while other people are doing that. And other people with a thinner window of tolerance might need more of the foundational trauma recovery skills, psychoeducation, coping strategies, strength-based work, whereas others in the group may have already spent weeks and months and years doing that, and they might get bored by redoing that again for too long. So we really want to assess each person's window of tolerance and try to put together a group where there's lots of overlap and similarities in the size and threshold of one's window of tolerance. Also helps to consider where each person's at in their recovery process from trauma. If we have a bunch of people that are brand new to trauma recovery, and we put them in a group with a bunch of people that are in phase 2, ready to do trauma processing, or even phase 3, where they've done some trauma processing and they're really ready to do that integrative work and focus on growing from trauma, meaning making, it really limits our ability to meet everybody's needs. It helps as much as possible to put together groups where people are all somewhat in a similar level, some similar phase of trauma recovery. And so, what I'm referring here to is the three different phases of most clinical maps for trauma work. And there's a whole nother video focused on this channel that I encourage you to check out. But just a simple overview, phase one is about safety, strengths, coping skills, psychoeducation. Phase two in trauma therapy is about trauma processing, about working with defenses, protector parts, about dealing with the rage and the grief and the despair and the harm, the memories. And phase three is about transformation, about post traumatic growth, about integration and meaning making. So these are the three phases of the clinical map for safely working with trauma. Some general criteria that I find helpful in screening for trauma therapy groups in general, and especially psychodrama groups, are the following: willingness to engage in trauma work, psychiatric stability, suicidality, psychotic symptoms, medications, emotional containment skills, and the ability to tolerate discomfort, behavioral containment skills, so we can ensure that this individual isn't going to disrupt the sense of safety for the rest of the group and other participants in the group, frequency or severity of drug use and alcohol use or other process addictions or behavioral addictions, the level of social support that an individual has in their life in terms of family or friends, an individual therapist, community support, peer support groups, and other support services, the expected length of time that the individual is going to be in treatment. I think this is especially important for inpatient groups, where somebody might only be an inpatient for 2 or 3 weeks. Doesn't make sense for us to put them into a trauma therapy group in inpatient if we know up front that their insurance is going to cut them off a week from now. Probably not. But if we know that they're going to be in treatment for 3 or 4 weeks, or based on our best guess, considering the medical criteria they're presenting with and the insurance policy that they have, we could expect that they're probably going to be in treatment for 2, 3, 4 weeks. That would make a little more sense to put them into a trauma group where we can open some things up, but also have time to integrate and close up what we've opened before they have to discharge. We also want to know about their ability to continue trauma therapy at the next level of care. So if we know that somebody's about to lose their insurance coverage, maybe it doesn't make sense for them to start trauma therapy for 2 weeks while they're an inpatient, knowing that they're not going to be able to continue treatment when they leave. It also helps to have some congruence between the individual's presenting symptoms, their issues that are important to them, their goals for treatment, and the larger group as a whole goals and issues that are going to be addressed. So these are really meant to be guidelines, just things that I found helpful in my work in assessing for trauma therapy groups specifically and psychodrama groups. And these are going to need to be adapted for each agency and for different levels of care and different treatment settings. Again, Yalom suggests that the majority of clinicians do not select for groups therapy. Instead, they deselect who's going to be appropriate for group therapy. So it's really important that we not only have inclusionary criteria and we have a sense of who we're going to include in this group, but also that we have some exclusionary criteria. Who are we going to exclude from this group for their own safety and for the safety of the rest of the group? Who's not a good fit for this group? Now, many of us, as helping professionals, we got into this field because we want to help as many people as we can. And we might have a tendency or an inclination to want to include everyone, regardless of where they're at in all of our groups. And yeah, this might be a good intention, but I found that it really doesn't work well unless you're going to do more of a phase one type of group that's focused on coping skills and psychoeducation and group cohesion and relationships. safety, and you're not going to get into heavy trauma processing. If you're going to get into heavier work and trauma processing and rage and despair and really get into the depths of pain with clients and their trauma, then we need to have more exclusionary criteria. So I really encourage us to consider this in our pre-group selection process. Now, we also need to think about group rules and group norms. In many ways, our group norms and rules provide the containment or the structure for safety and the expectations for participation in the group. Now, there's lots of simple group rules that we can implement to promote a sense of safety for trauma survivors within our therapy groups, including commitments to confidentiality, which most of us probably already use, commitments to mutual respect. And another commitment I like to use, another rule I use in my trauma therapy groups, is a commitment to ask permission before engaging in any kind of physical touch more than a handshake or a fist pound. That because trauma often leaves us with our nervous system being on edge or hyper aroused, and so many people experience trauma because of inappropriate or violent physical touch. When that's really up for people in therapy, it can really be activating to experience unwanted or unexpected physical touch, a hand on the shoulder or a hug. And so in all of my trauma therapy groups, I have some sort of rule about asking permission for physical touch. So these are 3 rules that I use in pretty much any of my trauma therapy groups or more involved experiential therapy trainings as well. Other rules are going to be important to include depending on your group and your treatment setting. For example, there might be rules in your agency that you have to also enforce, or there might be other rules about, like in an outpatient setting, you might have to have rules about people using their phone or silencing their phones during the group. Or in an inpatient setting, there might be other rules related to identification of clients being visible at all times, or food or drinks in the group room. These rules are going to vary from organization to organization. Other rules and agreements might relate to attendance and timeliness, being there on time, rules related to the financial aspect and payment for the group, and even other dual roles in the group. So we might need to create a rule about group members having contact in between group settings. And many group therapists will have a rule for their outpatient groups that individuals are expected not to talk to each other in between sessions or exchange phone numbers. Other group therapists, depending on the populations they're working with and the settings that they're working in, opt not to enforce that role or create that rule for their groups. As someone that's participated in therapy groups myself and facilitated outpatient and inpatient groups, I actually find that there's a lot of value to the relationships that are formed within the group and how those relationships can be a source of mutual aid and peer support in between group therapy sessions. So I don't include that in my rules. If I was working with different populations, I might include that in my group rules. It also helps to have norms related to choice within the group process, especially if we're doing trauma therapy groups. Anytime I'm doing trauma therapy, one of the first things I do is I affirm each client's right to choose how much they want to disclose and when and how, to disclose their trauma in a general way, in a specific way, to observe for some time before participating in the group, to choose not to share in the group, to choose how much they want to be involved. And that's really about safety. That if we're forcing people to do trauma therapy and to talk about their trauma, that's not going to be helpful, and it's potentially going to be harmful. It can help to have a norm related to telling war stories about trauma. I always say at the beginning of my inpatient trauma therapy groups that this isn't a place where we're just going to sit in a circle and tell war stories about trauma. That's probably not going to be helpful. Might be re-traumatizing for folks, might be vicariously traumatizing for others. And just retelling the trauma story again and again and again without doing the other important work might just be strengthening the neural pathways related to that trauma memory and associations attached to it. So I always have some sort of norm related to telling war stories about trauma, that there's a place for telling the story and the details of the trauma. And when we get to that, there'll be a structure and containment for it. And I'll be really explicit with the group about, all right, now the prompt is, I want you to share one thing you're ready to talk about as it relates to a loss you experienced or a trauma. I'll have a really specific prompt in a group setting when we get into details of the trauma. And that helps contain things. It can really help to have some sort of ritual for each group session about reaffirming and recommitting to group rules and group norms. So in my groups, what I do is whenever there's new group members, I spend a bit more time talking about the different group norms and the group rules. When I have a session and there's not any new group members, I very quickly go over the group rules and I ask everybody to commit to them. Regardless of if there's new people or not, the method I like to use to have people commit to the rules when I'm doing experiential groups in psychodrama is I outline the rules and I say, if you're willing to commit to these rules today, stand up. And what happens is everybody stands up. We get to quickly look around the room and visually see everybody's embodiment of their commitment to these rules. And now everybody's out of their chairs, and I can quickly go right into an experiential warm-up, some sociometry, or a psychodrama warm-up. It's pretty much every group I'm running, most of the groups I'm running, are experiential or psychodrama groups specifically. And when we're doing experiential work, usually the hardest thing to do is to get people out of their chairs initially. So doing it through the group commitment to the rules and norms kind of makes it a bit easier. Of course, if there were folks with physical limitations about standing up, or I had group members that were using a wheelchair, obviously I would modify that so that everybody could participate in it. What often happens in terms of enforcing group rules and norms is that early on in the group development process, the group leader ends up doing most of the maintaining of group rules and group norms, of enforcing them, reminding group members about them, holding group members accountable. But as that group goes on, what inevitably starts to happen is that the longer term group members start really enforcing and maintaining the rules and the norms with other group members. And that I want to say the responsibility of it, but the frequency that the group leader has to enforce the rules tends to decrease as other group members take accountability and responsibility and ownership of the group and naturally start to enforce these rules with their peers. So in terms of safety in group therapy, it's helpful to think about the physical layout of the room, as it can really impact the sense of safety and comfort for participants. So this means considering the furniture, considering the decorations within the room, considering the layout of the room. Are the exits clearly marked? Are the exits blocked? Like if we put the chairs in a circle in the group room, we need to make sure we do it in a way that individuals can still get to the exits if there's an emergency. I found throughout my career that many trauma survivors don't feel safe sitting with their back to the door. So I try to set up my group room in a way that it's generally in a circle of sorts, but with no chairs with the back to the door. Or if I'm forced to put a chair with the back to the door, I claim that as my chair, so that nobody else in the group feels like they have to sit with their back to the door. It really helps to use a circle of sorts instead of more of a lecture style setup within the group room, in that it provides a visual kind of symbolism that everybody has an equal place in a circle. Whereas a lecture style where everyone's facing the facilitator is more of a hierarchical group structure. So it helps to put the chairs in a circle of sorts. Now we need to make sure that there's privacy and that there's confidentiality within the group room, that the sound isn't carrying into the adjacent rooms or hallways, that the doors are closed, windows are closed, and that there's shades on doors or windows if necessary. We also might have to consider the organization's relationship to the group and the group place within the organization. I think this is maybe less relevant in outpatient settings, but uh, more relevant in higher levels of care. In my inpatient group, for example, uh, when we first started the group, it was really common for other staff members to pull patients out of whatever group they were in to sign a release form or to make a phone call with their case manager or their therapist or to go take vitamins or medications that they forgot to take that morning or to meet with another professional on the team. And that might be necessary on some level in inpatient settings and higher levels of care. But in facilitating a trauma therapy group, I found that to be really disruptive for the safety of individuals within the group. That if we're in the middle of some sort of trauma processing exercise and one of the nurses knocks on the door and opens the door and says, "Hey, I need to take Johnny. He needs to come get his medications." And we're right in the middle of somebody telling their trauma story or expressing anger or grief. It really disrupts the containment of the group and the safety of the group. So I had to advocate within the agency that it was not clinical best practice to be disrupting a trauma therapy group midway for any reason unless there's an emergency. And that's been the norm within the agency ever since. So you might have to advocate within your agency, create conditions and a container for safety in the groups that you're facilitating. This reminds me of one of social work's theories, the two-client system. Larry Shulman talks a lot about this, that as social workers, we really have two clients. The group is our client, and the agency, the system that we're working in, is our other client. And we have to actively work to create change within both the group and within the agency and system. In terms of disruptions, it also helps to have norms related to using the bathroom or stepping out of the group or using phones or anything else that would distract people so that you can really hold the container of the group. In group therapy, safety is also largely related to group cohesion and related to the matrix of relationships and connections within that group. So safety is often a prerequisite for social engagement, according to polyvagal theory and Stephen Porges' work. So we really have to cultivate safety in order to cultivate meaningful connections. And we also use our relationships to cultivate safety. So there's sort of a reciprocity there between connection and safety. Other experts in the field, such as Gabor Mate, have even suggested that safety is not so much about the lack of threat, but more so about the presence of human connection and emotional attunement within a relationship or within a group. So this is a really interesting way of shifting how we're thinking about safety, that it's less about disruption to safety or the absence of threat or violence or harm, and more so about the presence of connection and attunement. Now, many of the folks that we're working with in group work have been harmed in relationships, in groups, and in community or social settings. And so it makes sense if the nature of the trauma is relational or group or community related, that the healing from that trauma would also have to take place within a group, community, or relational context. And because so much of trauma happens because of other humans in relationships, I really find group therapy to be uniquely positioned and situated to help heal relational trauma. Trauma so frequently leaves us feeling a sense of mistrust, shame, and isolation. And group work is unique in that it provides correction through authenticity, through the normalization of experiences within the group, through the emotional support and peer support, and a sense of shared experience. I'm not the only one that's been through this trauma, this adversity, this experience of loss. When there's strong cohesion within the group, it will naturally lead to the embodiment of trauma-informed principles between the group members, that they'll be contributing to a sense of safety A sense of trustworthiness and transparency, empowerment and peer support and mutuality and respect, voice and choice, and addressing issues related to identity. So cohesiveness is really related to trauma-informed principles. In the early phases of group development, the participants in the group are primarily going to be connected to the group leader. And so that therapeutic relationship is going to be especially important in the early phase of group development. And part of the leader's task and responsibility is really to develop that therapeutic relationship and a connection to each individual within that group. As the group goes on and moves through the different developmental group processes, and there's a whole nother video on this channel that outlines those phases. A simple way to think about it is beginning, middle, and end phases. As we get into the middle and ending phases of the group, the relationship with the therapist perhaps becomes less important and less central, and instead the relationship between participants in the group becomes more and more important. Early on, the facilitator is often a role model for how others are going to interact with each other. One of my mentors, Larry Shulman, he often says, more is caught than taught. And this is true for us as educators and also for us as group facilitators, that our clients are constantly watching us and mirroring and reflecting and mimicking the things that we say, the behaviors that we're engaging in, and the ways that we're relating to others. So more is caught than taught. Some participants in a group might feel safer with a therapist than they will with other group members, but others are going to feel safer with their peers than they're going to feel with a group leader. There's lots of different ways we can promote safety in our relationship with group members. Sometimes our identity and sharing, being transparent about our experiences or our identities, our social location, our culture, it's going to be really important for group members to feel safe. Another important aspect is our nonverbal communication. What's our voice tone that we're using, our posture, our gestures? Are we engaging in physical contact with our group members, and how? Our personal disclosures and the level of vulnerability and transparency that we demonstrate can really help cultivate a sense of safety within our relationship with our group members. For some group members, our credentials and our role within the organization is going to help them feel safer and more trusting of us. But in general, the level of competence and skill that we demonstrate is going to help people feel safe. And of course, the level of empathy and compassion and understanding, passion that we have for our work, the wisdom that we demonstrate, the knowledge that we offer, and our ethics and integrity that we embody all cultivate a sense of safety with the folks we're working with. So I want to pause here and invite you to take a moment to reflect on your own group leadership. And what are some of the things that you could do as a group leader to help participants in your group feel safer and feel more connected? I want to talk about the second trauma-informed principle, trustworthiness and transparency, as it relates to leadership in group work and psychodrama. So, of course, as group workers, we're in a leadership role. We're leading the group. And we have to cultivate trust in our groups. We have to help clients to trust each other, to trust the process, and to trust us as facilitators. One really simple thing we can do to cultivate trust is to provide a simple outline or an overview of what the plan is for the session. This is something I push myself to do every time I teach and every time I lead a therapy group. I start off, I say, this is what the plan is for today. We're going to do this, then we're going to do that, then we're going to do this, then we're going to do that. Of course, I leave room for group choices and spontaneity within that, and I'll tell the group, at this point, maybe we're going to have a group choice, or the group's going to propose topics and choose a topic. But I clearly outline what the process is going to be and or what the content is going to be in the session. And this simple act of transparency can really help people who might be really hyper aroused or stressed about not knowing what to expect in the session, to really help them ground, to connect with some safety, and to be more trusting throughout the process. So, really simple thing to implement. Research suggests that one of the reasons clients discontinue group therapy directly related to their inability to trust the group or other members in the group. So, trustworthiness is particularly important between group members in a group. Others in the research said that the trusting bond within the group was one of the most important aspects for their safety in the group. So, group therapy research is showing that mistrust in the group decreases as the cohesion in the group increases. So, group cohesion is related to that first trauma informed principle of safety, but also related to the second trauma informed principle of trustworthiness. There's a author named John Allen who wrote a book called Trusting in Psychotherapy. And he says, to a great extent, trusting and trustworthiness are relationship specific, and they must be created anew in each relationship, developed, maintained, and repaired when disrupted. The creation is interpersonal. So this is a good reminder of how important trust is for relationships, for connection, and for group psychotherapy. So hyperarousal, is one of the main symptoms of PTSD, which is likely to make clients more hypersensitive and aware to the actions of the leader and other people in the group. So as leaders, we have to demonstrate that we're trustworthy, and we have to be able to repair ruptures when they occur, ruptures to trust and to the relationship. As a group leader, we also have to learn how to trust the process and to trust the group, to trust ourselves as facilitators, and to trust our training and our clinical instincts. This really requires us to engage in our own personal growth work and our own professional development. Really want to encourage you to pause here and reflect on how exactly are you continuing to engage in your own personal growth work, and how exactly are you continuing to engage in your own professional growth. Now, in talking about group therapy and peer support is the third trauma-informed principle outlined by SAMHSA, and it's particularly important in group therapy as well. Of course, our sense of self is really developed through our relationships and our experience with others. And through our experiences with others and our relationships, we develop these internalized versions of others, or we internalize messages about ourselves, about the world, about relationships from our experience with others. The field of interpersonal neurobiology is really highlighting just how much our brain and our mind develops in relationship to others. So when a trauma survivor sees themselves mirrored and respected and valued in the eyes of others and in group therapy, it can almost reawaken a part of the self, or help a trauma survivor reclaim a part of themselves that's been denied or amputated, to try to distance from the trauma, to distance from the pain, or the part of self that's carrying the pain or the burden or the trauma. Group therapy gives us a chance to experiment socially, to rediscover and redefine who we are in relationship to others. Through connections with others, we reconnect with ourselves. And peer support is one of the most important aspects in most group psychotherapy modalities, if not the most important aspect. In the social work with groups tradition, we call this mutual aid. In 12-step programs, they talk about there's nothing as powerful as one addict, one alcoholic helping another addict or helping another alcoholic. I mean, the power of peer support is really core in many self-help programs and many group psychotherapy modalities. In psychodrama, specifically, group work is fundamentally grounded in the importance of social connection. It offers group members an opportunity to practice social skills and experiment socially, to learn in action from the role modeling of the leader and the other participants, to renegotiate those core attachment styles that are developed in childhood. This sense of group belongingness that is cultivated in a cohesive group is a remedy for isolation. In many ways, group work is more powerful and more potent in this regard than individual work ever could be. There's a sort of healing nature that comes from peer support, from group cohesion, a sense of belongingness and mutual aid that is only accessible in group therapy and group work that's just not possible in individual work in the same way. When a group comes together with a shared goal, it helps everyone realize that they're not alone. It provides a sense of solidarity and a sense of a collective moving towards a shared purpose and a shared goal. Helps people feel like they're not alone. In the group, the painful experiences of the individual become normalized by the group sharing their experience. There's this all in the same boat phenomenon that emerges. Some people, group therapy might be the only time that they've connected with others who've experienced the same or similar traumatic experiences. And we can't underestimate the power of that. The validation from one peer to another peer that's experienced the same or similar trauma is often more powerful than any validation that a therapist or professional could offer. Some trauma survivors may need to first learn how to trust peers before they can learn how to trust a therapist or somebody that has power over them again. And this is something that we'll see often for folks that have experienced complex trauma, especially. The experience of peer support in group work is helpful for both parties engaged in the peer support process. The person receiving the support gets to receive help, care, empathy, new insight and perspective, new practical suggestions, new information, and support. The person offering the support leaves the interaction with a sense of pride that they were able to help someone else, a sense of value in themselves and their past experience, a sense of competence in their ability or self-efficacy in their ability to help others, empowerment, maybe even a sense of post-traumatic growth, enhanced respect for themselves and self-esteem. Mutual aid and peer support promotes role versatility in that participants in a group learn how to shift between being in a role of providing help and being in the role of receiving help. So it really can help people get unstuck and to access spontaneity, to access new roles and new behaviors. The collective strength of the group has a greater capacity to hold and integrate trauma and adversity than any single individual participant alone, or even any single therapist or professional. So peer support is particularly powerful. I want to challenge us to pause for a moment and to consider some of the ways that we've seen peer support and the healing and corrective power of peer support in the groups that we've been a part of. How has peer support helped us? How have we seen peer support and mutual aid be helpful for others in the groups that we've facilitated? This fourth trauma-informed principle of mutuality and collaboration is also really important in group therapy settings. Group really gives us an opportunity to experience a sense of belonging and collaboration and mutual respect. Trauma-informed groups especially promote a powerful sense of belonging for participants of that group. Many trauma survivors are going to struggle with a sense of belonging, which can result from their traumatic wound. Some have said that if we've been wounded in groups, then it makes sense that the healing must also come in groups. Judith Herman, who's a famous trauma expert, in her book Trauma and Recovery, provides a really powerful argument for groups as a remedy for trauma, as an avenue for healing from trauma. She writes that the solidarity of the group provides the strongest protection against terror and despair, and the strongest antidote to traumatic experience. Trauma isolates. The group recreates a sense of belonging. Trauma shames and stigmatizes. The group bears witness and affirms. Trauma degrades the victim, and the group exalts her. Trauma dehumanizes the victim. The group restores her humanity. I thought this was a really powerful quote from Judith Herman that really highlights the importance of group work in healing from trauma. Of course, not every participant in a group is going to feel as though they belong in every group. And perhaps there's different groups for different people. Nevertheless, as group workers, we have to ensure that our groups create a sense of belonging for those that the group was designed to serve. We have to ensure that our groups are not unknowingly unwelcoming or rejecting others, especially when we've actively invited them into the group. Of course, some groups are going to have exclusionary and inclusionary criteria or be created for certain populations or folks experiencing certain issues, and that's okay. But we need to make sure that the group is a welcoming place that promotes a sense of belonging for those that are there in the group. A sense of belonging is often included in discussions of diversity, equity, inclusion, and group work as well. Belonging is elevated beyond simply being given a space or a voice, but to include that one's voice is heard and responded to by others. So we can't just give someone from a marginalized background space. We can't just give them a voice, but we also have to hear their voice and respond to their voice, which creates a sense of belonging. SAMHSA actually describes group cohesiveness as being related to the sense of belonging that an individual experiences in the group. So we can see that there's even a connection between group cohesion and mutuality and belonging. This principle of collaboration really speaks to the shared purpose and vision and goals within a group, that collective reason why the group is there and what the collective goal is together. A cohesive and collaborative group process promotes the presence of therapeutic factors that were outlined by Yalom, especially those of a social nature, such as the imparting of information, altruism, the development of socializing techniques, imitation behavior, and interpersonal learning. Collaboration and mutuality often exist in a reciprocal relationship with each other in cohesive groups. That the more collaboration there is, the more a sense of mutuality and mutual respect is going to emerge. And the more mutual respect we have for others, the more collaboration we're naturally going to engage in. So I want to talk more about this fifth trauma-informed principle of empowerment, voice, and choice as it relates to group therapy and group work specifically. So group work is unique as an intervention in its effectiveness and its capacity for empowerment, voice, and choice. The mutual aid process and the peer support within the group initiates a collective sense of empowerment for the entire group. The group that taps into its collective power initiates a parallel process of each individual accessing and harnessing their own internal power and their own sense of empowerment. So the power of the group is really, really potent in cohesive and safe groups. Part of this empowerment process helps individuals reconnect to a sense of autonomy, a sense of choice, and a sense of ownership within their own lives. Many times in the group process and the trauma recovery process, the fundamental skill of boundary setting and making choices becomes really central and really a key component of learning and practicing within the group process. This trauma-informed principle of choice promotes a reconnection to autonomy for the trauma survivor, who often might feel like they've lost their sense of autonomy or control over their life because of what they've gone through. Group therapy and group work provides a variety of opportunities for voice, for choice, and for empowerment. And there's something unique about the experience of giving voice to your wants, your needs, your feelings in a group setting compared to an individual setting. There's a increased power to it in a group in terms of being witnessed, being heard, being seen in a social setting, especially if we've started to lose our sense of trust that others are going to hear us when we talk, are going to take us seriously, are going to even believe us when we tell them about our experiences. So there seems to be something specifically unique about group work and its advantages over individual work when it comes to this trauma-informed principle of voice and empowerment. So I want to challenge you for a moment to reflect on your own experiences of being in groups, of being in classrooms or communities that felt empowering. What was it specifically about those experiences in group settings that made it feel empowering? What were the factors that led to the sense of empowerment? What were those factors on an individual level and on a collective level? And how can we actively work to cultivate those factors in our own groups? So, this sixth trauma informed principle, addressing issues related to identity, culture, gender, history, is particularly important for group therapists and group leaders. So, groups have a real unique potential to promote healing from discrimination, from oppression, and from collective trauma. That's simply going to be impossible to access in the same way through individual therapy or one on one work. Group work is going to offer exponentially more opportunities and potentialities for corrective emotional experiences related to discrimination. And this really becomes concretized in the group, felt in the group, through a sense of group solidarity, a group acceptance, and a sense of belongingness within the therapy group. In the history of group therapy, group work really emerged through social reform. It was influenced by democratic principles and social action, social responsibility and advocacy, social justice, and empowerment for oppressed communities. And this is particularly true in the social work with groups tradition when we trace our history back. However, many of the most popular contemporary group therapy approaches really fail to adequately address issues of culture, diversity, and oppression. So, considering our biases, considering diversity and oppression and social justice is not just a clinical issue, but really an ethical issue for group therapists to consider. Without cultural humility and an anti-oppressive stance as group workers, we're really prone to inadvertently falling into traumatic reenactments or re-traumatizing individuals in our group related to issues of identity, oppression, and marginalization. So cultural competence really is a poor way, a flawed way of looking at it. We're never going to be competent in a specific culture that isn't our own. Instead, a better framework that's been proposed is looking at it through the lens of cultural humility, which recognizes that we're not the expert in other cultures and that we need to approach the work in the spirit of humility. However, many have suggested that cultural humility is also flawed in that it's a passive approach to the work, and that instead we should strive to embody cultural responsiveness. So cultural responsiveness means that we approach the work through the lens of cultural humility, but that rather than just taking a passive stance, we're responsive and we take action around issues of identity and culture. So there's some recommendations that were offered by Burns and Ross in a 2010 publication. Recommendations for incorporating anti-oppressive methods into group work and group facilitation. Some of the things that they recommended were that in our intake questions, we also include prompts and questions to participants when we're pre-screening for participation in group about their ability and willingness to have discussions about identity and about oppression. They also recommended that we consider diversity and intersectionality in the developmental phases of the group and the development of the group as a whole. The third recommendation they offered was that we use structured activities that center around issues of privilege and oppression within the group. That we're not just aware of it and asking about it in intake, but that we're also interfacing with it within the group. And the fourth recommendation they offered was that we are processing here and now issues related to oppression in the group here and now as they emerge, that we're taking the time to address those and try to work through them in the group experience. In my own work, I found that it becomes really important to also include some group norms and some group rules that name issues of identity and ask participants to commit to respecting each other's different identities, belief systems, religions, gender, sexuality, race. So, in all of my therapy groups and training sessions, whenever I go over group rules, I include a group rule about mutual respect based on identity. And I find this to be helpful because it sets the tone early on that right from the start, in talking about confidentiality and safety, we're also mentioning identity, and it's opening up the setting the tone really, and ensuring that the facilitator is the first person to mention issues of identity, and opening the door for those issues to be explored throughout the group process and brought up by other group members. So, oftentimes in our group facilitation, we might, or other people in the group might, experience microaggressions during a group therapy session. And so we have to consider how we're going to respond to microaggressions in real time. We can't just ignore them. Then somebody or part of the group is going to feel ostracized, is going to feel hurt, is going to feel shamed, is going to be angry, is going to feel rejected. Though many times when I've seen people address microaggressions, they do it in a way that is incredibly shaming and leaves other people or another person in the group feeling isolated, ostracized, and shamed or rejected. So I think there's a middle ground somewhere in that the way that we respond to microaggressions can be informed by the spirit of trauma-informed care and these trauma-informed care principles. So how do we respond to a microaggression while promoting a sense of safety for the person we're responding to, but also preserving the safety of the rest of the group? By embodying the spirit of transparency, trying to recultivate a sense of trust in the group after a rupture is caused by the microaggression. By leveraging peer support in the aftermath of a microaggression or the midst of a microaggression. By addressing it in the spirit of collaboration and mutuality, holding on to a sense of respect for the person who made a mistake and engaged in a microaggression, while also challenging them to reclaim a sense of respect for the people or person that they directed a microaggression towards. How do we empower individuals in the group who are hurt by the microaggression to speak their truth about how they experienced that? And how do we empower the person who engaged in the microaggression to take accountability for their action, their behavior? So I think these trauma-informed care principles can really help guide us in our responses to microaggressions. So often I've seen facilitators respond to an individual who engages in a microaggression by reciprocating and matching, or even outdoing their anger, shame, or rejection, and projecting that all right back onto the individual, which really is not helpful, I think. In many ways, the person who's engaging in a microaggression might not realize what they've just said is harmful to others. And many people engaging in microaggressions are really engaging in the psychological defense mechanism of projection, that they're projecting something out onto another group. There's a great book by a former Gestalt therapy trainer and social work professor at Bryn Mawr College. The book is called Encountering Bigotry, Embracing Projecting People in Everyday Life. And it's exploring exactly this. What is going on psychologically and on a social emotional level when somebody's engaging in a microaggression or saying something insensitive saying something racist, saying something homophobic. What exactly is going on for them emotionally? And the authors of the book suggest that when somebody's making a racist joke or engaging in a microaggression, that it seems like they're creating an in group and an out group, and they're positioning themselves in that in group. And that one of the primary reasons somebody might feel compelled to create an in group and an out group, a separation, and position themselves in an in group, is that they're feeling anxious, they're feeling threatened, and what they're really seeking is connection. And so, considering this as a defense, a projection, how can we as facilitators promote connection while holding somebody accountable for their microaggression and addressing the harm that it causes within the group? So I don't have all the answers on that one. I've had my own experiences as a group leader of missing microaggressions and not addressing it in real time and having to come back to it. I've had my own experiences as a group leader of feeling like something just happened in the group that didn't feel right, that was a microaggression, but feeling paralyzed and not knowing how to respond to it in the moment and missing the opportunity. And I've had experiences as a leader catching a microaggression, but responding in a way that just fueled more separation and more disconnection and more shame. And then I've had a couple instances where I think I've responded in really good ways that provided an opportunity for accountability and repair in the group, preserved the safety and protected individuals in the group that were being harmed by the behavior, while also fueling repair from the rupture that was created. So I think this is something that each of us as facilitators is going to have to practice, is going to have to explore based on our own identity. The way I respond as a white, straight, cis guy leading a group, the way I respond to a microaggression is probably going to be different than somebody else with different identities. My own personality and style might be different than other people's personality and styles. So you're going to have to find your own way of how you're responding in these situations. So I really want to encourage you to reflect on this for a bit. How are you explicitly incorporating and addressing issues of identity, oppression, and discrimination in your groups? Are you avoiding discussions related to identity when they emerge in the group? Or are you embracing them and addressing them, leaning into them, even when they're uncomfortable at times? Group leader that fails to consider the influence of larger social and cultural forces, aspects of identity within the group process, is failing to fully embody a trauma-informed approach. Yalom suggests that the group is a microcosm of society. Therefore, the same issues of oppression and discrimination that are present in society are going to show up within our groups. Without attending to these issues of social justice and culture, identity, our ability to cultivate the therapeutic factors within group is going to be pretty inhibited. So I encourage you to reflect on how are your own identities impacting your perspective as a group leader and even your approaches to group work. And how might participants in your groups experience you based on your gender, based on your race, based on your age, and based on those other aspects of identity? So this sixth trauma-informed principle about culture, identity, gender, history is also particularly important in organizational settings.